Wonderful talk. We're going to save the questions for the discussion, so I do want everybody.
Okay, so but I'll be saying bye.
Okay. All right. So we'll send emails, questions if needed for the first talk.
I think all of us are going to be saying bye.
All right. Safe travels. George Zenonos is going to give us the next talk, revisiting operability within the cavernous sinus.
Well, thank you very much for the invitation, Dr. Morcos. Dr. Sami, I didn't have the pleasure of training under you, but Dr. Morcos speaks about the ripple effect. And I think I'm perhaps one of the people that were trained under people that were trained under people that were trained under you. So, you know, the circle expands, and it's a real pleasure to be here today. So, I don't have any relevant disclosures. Obviously, the skull base is a complicated place, and especially the cavernous sinus is one of the places that has been feared over the time. Dr. Vinko Doling was perhaps one of the major pioneers that pushed the envelope, but still is kind of considered kind of a high stakes surgery. Over the time, there's been things that been done to try and decrease our footprint, perhaps decrease the morbidity of the exposures. And this is an example of that, perhaps with a smaller incision. We talked about having complete control over things, but sometimes only paying for what you need is also a good strategy. And this lateral orbitotomy can give you like enough of an exposure, exactly what you would have needed from perhaps a modified orbiozygmatic, where we, apologies about that, where we peel the lateral wall of the cavernous sinus, the cavernous hemangioma, and achieve what we would have achieved otherwise, going in between just up above V1 and using neurophysiology. Sometimes we don't have to get into the cavernous sinus completely. This is a cavernous sinus aneurysm that was completely that was thrombosed. Tried multiple times to traverse it endovascularly, but it was impossible. It was complete cavernous sinus syndrome. And I'm not going to belabor this. You've seen fantastic bypasses today and very elegant surgery, but this is an ECI bypass. And the challenge here is to perhaps preserve the ophthalmic artery, and that's where the cavernous sinus comes in. When we do an enterocleinidectomy, we by entering the choroidal membrane, opening the distal dual ring, but going further, a little bit further than that, then we're able to place a clip proximal to the ophthalmic. We saw beautiful examples earlier today to try and preserve the ophthalmic artery. But still, again, the cavernous sinus has been challenging, and coming from lateral approaches has been deemed many times unsafe, and with the advent of radiosurgery, many times has been deemed as no man's land. Nonetheless, with neurophysiologic monitoring that has advanced and approaching the anatomy from another perspective. So instead of approaching from laterally and talk about in triangles, perhaps approaching it from endonasally. My partner has a good analogy to that. It's like trying to approach a porcupine from the side versus turning on his belly, where it becomes a lot more approachable. This is an example of a clivochordoma involving both sides of the cavernous sinus, and this is how we work together in motor skull-based world, and with our NT partners. It was like co-pilots in a plane, but then being able to enter the cavernous sinus and resect the tumor from that, particularly when the tumor started from medially and pushed laterally as opposed to the vice versa. And surgery within the cavernous sinus, particularly for softer tumors such as pituitary surgery, has become more or less routine. We tend to think about compartments more than the triangles to access it. And by thinking about the compartments, we also think about whether the structures are there, the superior compartment with the third nerve, the fourth nerve, et cetera. We mentioned earlier that we can use the oculomotor triangle to follow the tumors from the pituitary fossa through the oculomotor triangle, the posterior roof of the cavernous sinus, into the prepontine, into the crural space, and the ambient cistern. The posterior compartment with the sixth nerve, the infralateral trunk, posterior to the genu of the carotid artery. The inferior compartment tends to be a little bit more forgiving, with only the sixth nerve being there. But the lateral compartment has been traditionally a problem, and there's been morbidity in accessing that compartment. That's been one of the focuses of recent endeavors to try and unlock that area and make that the surgery in that compartment safer. And this is a schematic from one of our fellows. I think one of the keys here to unlock is like a complete dural exposure all the way from the proximal dural ring down to the foramen lacerum, opening the cavernous sinus, but then coagulating and dividing the infralateral trunk. That's what really kind of unlocks the carotid artery to be mobilized medially. As an example of a case that we did, is a recurrent meningioma after radiation that was kept progressing. The patient presented with a third nerve palsy. You see the progression of events here. A partial third nerve palsy with ptosis, but also significant trigeminal neuralgia with sharp pain along the V1 distribution. This is a combined endonasal approach, but also did a transmaxillary approach on the ipsilateral side, and really do a wide approach here. And these are, you see the carotid artery. Then now I'm opening into the cavernous sinus, identifying the normal gland, and then essentially opening all the periosteal layer of dura up to the proximal dural ring. Once we do that, we can start mobilizing the carotid artery. This was thankfully not a very relatively softer tumor. If this is completely a fibrous tumor, then you can really not do much. Here's a sixth nerve that comes into view. But my goal right now is to find the infralateral trunk. And once I find the infralateral trunk and coagulate and divide it, then we're going to get a lot more mobility of the carotid artery. This is important because if you avulse the infralateral trunk on the horizontal petrous, of the horizontal cavernous carotid, that creates quite a bit of an issue. We want to separate this from the sixth nerve, which is essentially attached to it. And then here's how we can completely mobilize that carotid artery medially. So working also lateral to the sixth nerve here, slowly and sequentially. You have to be mindful of the carotid plexus as well. People can get partial Horners from this, and following this anteriorly into the supraorbital fissure. Here I'm seeing V2. That's why we're switching back to a transmaxillary approach. And this is the final result. This was a grade 2 tumor now after radiation. But thankfully, with resolution of the patient's symptoms, the third nerve palsy, and also his pain. I'm not going to belabor this. Is another giant pituitary adenoma, invasion of the lateral compartment. Similar thing, lateral, medializing the carotid artery, coagulating, dividing the infralateral trunk, and being able to resect the tumor from this compartment. These are some of the data. The soft tissue components around the cavernous sinus, I believe I'm still having a little hard time with the existing literature. This is work again from one of our fellows, introducing that sleeve of meningeal dura around each nerve. The medial wall of the cavernous sinus there's been a lot of talk about it recently with the carotid, the pituitary ligaments, and Dr. Juan Fernandez Miranda has very accurately described this. It does increase the remission rates particularly after functional tumors. This is a sort of a particular case where we had an acromegalic with invasion of the medial wall of the cavernous sinus, but also if you have a physical artery in the field. And then it's still possible, is sort of an unusual case, but you see some of the steps of it are the same. except that we do a little bit more of an extensive exposure. This for securing proximal control here in the cavernous sinus, separating from the sixth nerve. Here's the normal gland. And then, again, making the dissection, mobilizing the wall of the cavernous sinus medially and isolating the aneurysm. And then finally putting a clip on it. Here are the supraepithelial vessels that are nicely preserved. And the patient nicely went into remission. Sometimes the cavernous sinus is a conduit. We don't really need to do anything in the cavernous sinus itself, but it can provide us access, for example, endonasally after removing the posterior clinoids to the interpeduncular cistern. This is a midbrain cavernous malformation that was involving the third nerve. And then I thought this would be an ideal approach for it. Opening the cavernous sinus on each side here, doing this interdural pituitary transposition. You have to coagulate and divide the inferior habitual artery on each side. Again, this was work that was accurately described by Juan Fernandez Miranda. Then you have to expose the posterior clinoids from the surrounding ligaments, intraclinoidal, posterior petroclinoidal, Gruber's ligament, etc. It does require a team with an experienced ENT surgeon that's invested in providing good driving in this narrow spaces. But here are the posterior clinoids coming out. And now we're coagulating and dividing the supraendocavernous sinus and making sure that we're not coagulating and dividing the supraepithelial vessels that are not as forgiving as the inferior epiphyseals. And then connecting the suprasellar with the posterior fossa, opening into the membrane of Lilliquist. And then here is the cavernous malformation, the PCOM. And this ended up being a nice approach into it. Another example of such a case is this giant epidermoid tumor. I really didn't know of another approach that could allow us to get everywhere within this tumor, going so high in the prepointed cisterns, in the intercrural cistern. And I did about the same thing in this case with my NT partner, Dr. Eric Wong. But again, removing the posterior clinoids, connecting the two worlds. Here are the optic tracts and sharp dissection of the basilar. And not a complete resection, but a good decompression here. Sometimes access into cavernous sinus may be useful for proximal control of parathalamic aneurysms. We heard beautiful talks about approaches to them when endovascular treatment is not indicated. There's one example of a kind of a low-lying ophthalmic artery aneurysm. She had contraindication to antitherapy. And we chose to treat this. Also, they were a little bit worried because the ophthalmic was coming off the aneurysm itself. Can argue it's a smaller aneurysm, but it's a younger lady that really wanted to treat it. So gaining access intracavernous, getting proximal control into the ascending petrous there. And then opening to the cavernous to completely open that carotid cave, distal dural ring, divided, exposing the aneurysm. Allows a little less manipulation of the optics here, especially with these lower-lying aneurysms. And again, being able to place a clip with preservation of the ophthalmic artery, as we saw in ICG, but also in intraoperative angiogram here. This is sort of the similar story, but more of a carotid cave aneurysm. I was more worried about vascular control here. Here's the aneurysm here, sort of, it was arising distal to the origin of the ophthalmic, which was also above the distal dural ring, but this was invagining into the diaphragma, find this aneurysms quite difficult to manage coming from a lateral approach, although it's definitely doable. I'm not going to belabor this. This can be done bilaterally. This bilateral ophthalmic and supraepiphyseal aneurysms. And I'm going to close by saying that operativity in the cavernous sinus is being redefined. The ventral approaches decrease the necessity of manipulating the cranial nerves. It's not that it's not possible, but if you can avoid manipulating the cranial nerves, it's also beneficial. But it does require appropriate case selection to be able to have safe and optimal outcomes. Thank you.
Thank you.